The following podcast is part of a certified educational activity titled Elevating Psoriasis and Comorbidity Management with TYK2 Inhibition, Achieving and Sustaining Outcomes to Transform Care. Access the entire activity and complete the post-test at peerview.com/SMF860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. April Armstrong. I am a professor and chief of dermatology at the University of California at Los Angeles. Thank you for joining me on this educational activity titled Sustaining Outcomes, Transforming Care in Psoriasis and Associated Comorbidities, Elevating Management with TYK2 Inhibition. I am so excited that you're here with me today, and we will go over several important learning objectives. And hopefully at the end of this session, you'll be able to take away clinical pearls that you can put into clinical practice the very next day. So our goals for today are threefold. Number one, we're going to enhance your knowledge of the pathophysiology driving psoriasis and the related comorbidities. Number two, I'm going to walk with you through a few case studies and help you prepare to identify ideal patient candidates for TYK2 inhibition in psoriatic disease management. And number three, we're going to talk about the best strategies in terms of developing team-based, individualized psoriasis care plans for patients. So first, let's think about a question. Can we improve the treatment experience and outcomes on the psoriatic disease spectrum? So when we think about psoriatic diseases, we talk about psoriasis as well as psoriatic arthritis, and they come in different morphologies and they come in different severities. And we're really going to contextualize all of this in terms of patient cases. And hopefully, as we go through these patient cases, you can think about your own patients as well and identify some of your patients in the patient cases that we will go over. So first, let's meet Jeff. Jeff is a 36-year-old man with new complaints of a rash. So let's take a look at Jeff. Jeff tells us that he's noticed this red flaky plaques for the past 5 months, and he's never seen them before. And he hasn't been diagnosed with psoriasis before. You see that this rash covers about 11% of Jeff's body surface area. They're overall well demarcated erythematous plaques with moderate flaking and scaling. And you see in here Jeff's picture. Now, we know psoriasis can present differently in different patients. And it's important not only do we look at the image of the leg, but also make sure that we do a full skin exam of Jeff, and especially checking for areas that may give us pathognomonic clues of psoriasis. For example, psoriatic involvement in the umbilicus typically is almost very pathognomonic of someone having psoriasis. Also, involvement of intergluteal fold, that's oftentimes a very specific clue that the diagnosis can be psoriasis. So, few things as we kind of go along with Jeff's presentation to think about is how do Jeff's symptoms align with the clinical presentation of psoriasis? Does he meet the criteria for diagnosis, which is typically a clinical diagnosis? And also, how would you classify the severity? Now, if we look at this particular image, we see that the areas or erythematous is somewhat scaly. We don't see the periphery, the well demarcation as well. Sometimes while psoriasis is classically thought to be well demarcated, sometimes in some of our patients, we do know that the margination is not as well demarcated. So multiple clues oftentimes are needed in the more difficult to diagnose cases. Additionally, in our patients with more darkly pigmented skin color, it's important to know that psoriasis oftentimes present as this a darker violaceous color, sometimes could even be gray, and sometimes the color can be even towards more kind of a bluish purple coloration. So it's very important to understand that the psoriasis can not present classically as the red color that you see in lighter skin individuals as you would in darker skin individuals. Okay, so we'll keep Jeff in the back of our mind and we'll continue to think about psoriasis as a disease that not only affects the skin, but also there are a number of important comorbidities that we oftentimes think about. And those include, for example, cardiovascular disease, inflammatory bowel disease, as well as cardiovascular risk factors, things like diabetes, metabolic syndrome, and importantly, mental health comorbidities that can be associated with psoriasis. Importantly, about a third of the patients will develop psoriatic arthritis. So that's something that's very important to keep in mind, and we'll come back later on to this important point as well. So, how do we classify psoriasis severity? Well, historically, it's been categorized as mild, moderate, and severe, depending on patients, oftentimes depending on their BSA. But we recognize that this classification may not recognize other burdens in our patients with psoriasis. So a few years back, this was reclassified based on the International Psoriasis Council in terms of thinking our patients with psoriasis as candidates for topical therapy versus candidates for systemic therapy. Now, it's probably easier to think about patients as candidates for systemic therapy or phototherapy and what that entails. So, those are for patients who have body surface area 10% or more. And very importantly, the word is or, not and, or they may have disease involving high impact areas, sometimes called special areas. And those refers to as, for example, hands, palms, soles, genitalia, scalp, or nails. And then finally, if they have failed topical therapies, we want to consider them as possible candidates for also systemic therapy or phototherapy. Now, when we think about our patients with psoriasis and really think about these high impact areas, we now have come to appreciate that the involvement of high impact areas actually occurs in a vast majority of our patients. So, for example, when we look at the prevalence of scalp disease, up to about two-thirds of our patients can have scalp disease when we examine them. That's why it's so important when we look at our patients with psoriasis to always examine their scalp and to see if they have any scalp involvement. And anywhere between a third to about 40% of the patients will have facial involvement as well. And you can see also from this slide, about a quarter of the patients will have genital involvement or nail involvement or palmar and plantar involvement. And importantly, it's also important to recognize that many patients may have two of these high impact or sensitive areas that are involved. So treating our patients, not only treating the truncal lesions, but also ensuring that these high impact areas are also addressed is very important. And now let's go back to Jeff and let's revisit Jeff and look at some of the severity measures. You will see that Jeff has about 11% body surface area of these plaques involved. So this is important. So this is above 10%. So this automatically puts Jeff in the category where we think about systemic therapies. His PGA is 3, which is moderate. And very importantly, his DLQI score is 13, which relates to the significant impact that his psoriasis is having on his overall quality of life. So we established that he meets the criteria for diagnosis through clinical examination. We also established that Jeff qualifies for a systemic therapy having BSA greater than 10%. Now, let's think about our therapeutic options. In this day and age, we have numerous therapies for psoriasis and especially plaque psoriasis. And they fall into these 4 categories of topical therapies, oral therapies, injectable therapies, or biologic therapies and phototherapies. It's very important that when we think about our patients, that we undergo this shared decision-making process and really understand their preference for the various medications and various administrations of medications. One thing I often talk to my patients about after reviewing the efficacy and safety of some of our medications is really thinking about whether they prefer an oral medication or an injectable medication. The reason is because if a therapy or 2 therapies can deliver about the same efficacy or have a similar safety profile, then patients' preference in terms of how they would like to take the medication is really important because their patient preference is likely going to also dictate their adherence to the therapies and ultimately their outcome as well. Now, keeping those in mind, we're going to go to the next section where we're going to dive a little bit deeper into the molecular drivers of psoriasis and comorbidities, and then later on how our therapies and especially TYK2 inhibitors affect some of the key molecular pathways. This is an article that I published in JAMA. So this is from 2020. And I encourage you to read it because it goes over all of the key pathogenic details for psoriasis. And importantly, layered on top of that, it also talks about some of our systemic medications that really address these key pathways. So one of the key molecules, what we called master regulator of psoriasis, is IL-23. And why IL-23 is important is that IL-23 leads to the survival and proliferation of Th17 cells, which then secrete IL-17. So we know that Th17 cells and IL-17 downstream is very important for psoriasis pathogenesis. And so we have this, what we call IL-23 and IL-17 or IL-23 and Th17 axis, where it starts with IL-23 and then continuing on ending with IL-17 and as well as TNF alpha in terms of the psoriasis pathway. So affecting the IL-23 pathway is extremely important. Now, you may ask, what happens when IL-23 binds to its receptor? And so this is where the intracellular pathway conversation comes in. So in this particular slide, what you see is that IL-23 can bind to the receptor, and then in order to transmit the IL-23 signaling, TYK2 is very much involved in this pathway. Now, it's also important to know that aside from IL-23, there are other pathways that can contribute to psoriasis pathogenesis, and that can include the interferon alpha and interferon beta pathway, and that also involves TYK2. So TYK2 is really important intracellularly for that signal to be transmitted from extracellular cytokine binding to the receptor, and then how that signal gets transmitted intracellularly requires that of TYK2. You'll notice that TYK2 is very specific for Th17 differentiation, Th1 differentiation. Now, TYK2 belongs to a family of Janus kinases, and there are other members of that Janus kinase family, which now you see on the right side of the slide. And these other family members are involved a bit in other pathways, so metabolic pathways, for example, hematopoiesis. But TYK2 is an ideal therapeutic target because it's very specific to the immunologic pathways that's hyperactive in psoriasis. Now let's take a closer look at the role of TYK2 in the pathogenesis of psoriasis. Here we have type 1 interferons, that's interferon alpha and beta, which are very important in the beginning of the pathway. And that particular pathway is mediated by TYK2 intracellularly. Through that, you have expression of IL-23, and in order for IL-23 to act intracellular, in order for the signaling of IL-23 to be transmitted, intracellular activities of TYK2 is involved as well. So essentially, when you want to have the intracellular signaling of type 1 interferon, and then later on the intracellular signaling of IL-23 to be mediated, both of those require the action of TYK2. And then importantly, the TYK2 partners with another member of the JAK family, and that attracts STAT molecules to the receptor, to the intracellular part of the receptor. They get phosphorylated, then the STAT molecules go into the nucleus where they initiate gene transcription. What kind of gene transcriptions do they initiate? for example, IL-17 gene transcription is initiated, and IL-17 can further promote the proliferation of keratinocytes and leading to epidermal hyperplasia. And that's when we see clinically thickened plaques as well as lots of scale that's involved. Now let's zoom into TYK2 and really think about how TYK2 is different structurally from JAK1, 2, and 3. So what you will notice is that in this depiction, all the members of this family have the active site. So they have when we're looking at each member has essentially two different domains. So they have an active domain, which is the ATP binding site. And you'll notice they're very structurally similar to each other because they all bind the same substrate, ATP. However, they also have a pseudodomain, which is to the left. That's a regulatory domain. The regulatory domain is very much more specific to the members of the family. So you can really think about the regulatory domain on the left side depicted here is a lot more specific to each molecule. And therefore, by binding to the regulatory domain, you get more specific inhibition of that particular molecule and without touching the other members of the family. So for example, when we're thinking about deucravacitinib, which is a TYK2 inhibitor, it doesn't bind to the ATP binding site. Rather, it binds to the regulatory domain. And because the regulatory domain structurally is more distinctive, it only affects deucravacitinib activity, principally affects TYK2, while leaving the activities of JAK1, 2, and 3 alone. And let me show you some of the data further supporting this. So in this graph, you see different medications that's listed across. The last one here is deucravacitinib. The bars represent daily inhibition of different activities, whether it's TYK2 activity or JAK1/2 or JAK2/2 activity. So if you look first to the very right side of this slide, you'll notice is that deucravacitinib daily inhibition only affects TYK2. It has minimal effects on JAK1 and 3 and minimal effects on JAK, if any, on JAK2. If you look at the other medications, tofacitinib, upadacitinib, baricitinib, they are primarily JAK1 inhibitor with various other inhibitions of JAK2. Typically, we want to avoid JAK2 inhibition because that's the inhibition that affects our hematopoiesis. But you can see the bars are gray, which represent inhibition on the JAK1/3 activity. And then the dark blue bars represent active inhibition for JAK2/2 activity. You don't see much light blue bars at all. So as you can see, deucravacitinib acts differently, quite differently from the JAK1, 2, and 3 inhibitors. Okay, now having looked at the pathophysiology of psoriasis and the MOA of deucravacitinib, and also why TYK2 is so important to inhibit in psoriasis. Now, let's go back to the clinics. And I hope you remember Jeff. So we're going to take a look at Jeff again, and then also look at some of the supporting data for the use of TYK2 in patients like Jeff. So let's go back to Jeff. You remember Jeff has moderate psoriasis with 11% of the body surface area involved. So let's take a look at Jeff's labs. His interferon gamma release assay, so quantiferon's negative, and we'll talk about this a little bit later. Universally in all patients, that is the only required pre-lab to check for all of our patients. Now, for your patients who may have hepatic comorbidities, you also want to check LFTs and hepatitis serologies. So for Jeff, those turned out to be negative as well. So we may think, is Jeff a good candidate potentially for oral therapy? Well, after talking with Jeff expresses a preference for oral treatment. So when I look at Jeff, more moderate in terms of the patient presentation, and also have these 11% body surface area, so more on the moderate end of the moderate to severe disease spectrum. So I would say that Jeff would be a very good candidate for oral therapy. And let's take a look at the clinical data for deucravacitinib and see if Jeff is a good candidate for deucravacitinib. So here we're looking at the phase 3 pivotal studies. There were two sister studies, POETYK-PsA1 and POETYK-PsA2. They are identically designed up to week 24. And what you see, if we look at POETYK-PsA1 here, is on the left-hand side, you see three lines. The top line represents deucravacitinib, the middle line represents apremilast, and the orange line represents placebo. And so what we're looking at here is the primary endpoint, PASI 75. So what you notice is that by week 24, deucravacitinib, about nearly 70% of the patients on deucravacitinib will achieve PASI 75 compared to about 38% of patients in the apremilast group. So we actually learned a lot from this clinical trial, and when the results were unveiled, it was very monumental at the time because it was the first study that rigorously looked at two advanced oral therapies. And what we learned from that is that deucravacitinib's efficacy is twice that of apremilast by week 24. And then when you think about how many pills patients have to take, so with deucravacitinib, it's once a day, and with apremilast, it's twice a day. So you have a medication that's once a day that have twice the efficacy as apremilast that's taken twice a day. Now, this is for the moderate to severe patient population, and I think we learned a lot from this particular clinical trial. I shall say that apremilast is approved for patients with plaque psoriasis regardless of disease severity. So I think apremilast can be, for example, ideally used in patients who may have mild severity, who are not responding to topical therapy, but who have mild psoriasis severity, and apremilast can still be used on label for those patients. However, for patients with a moderate to severe psoriasis, as you can see here with this head-to-head comparison, we do see deucravacitinib being twice as efficacious as apremilast. How about long-term data? We now have 5-year data with deucravacitinib. It has been approved for a while now. And when we look at the 5-year data, we learned that about 75% of the patients will maintain PASI 75 around 5 years. So if your patient has good response to deucravacitinib to start with, the likelihood of them maintaining that good response is high. And again, it's what I call 75% on 75. So about 75% of the patients will maintain PASI 75 through 5 years. What about the safety of deucravacitinib? Overall, what we see is that deucravacitinib has a very good safety profile. And because we have head-to-head comparison with apremilast and also comparison with placebo, overall you see that there's no increased rates of non-melanoma skin cancers, there's no increased rates of internal malignancy, there's no increased rates of serious infections. The herpes zoster rates were numerically higher in deucravacitinib versus the apremilast or the placebo during the placebo control period. However, long-term, when you're looking at the herpes zoster rates, the rates are comparable to patients with moderate to severe plaque psoriasis, and rates were comparable to actually biologic-treated patients. And then when you look at the thromboembolic events, what we see is that the rates were not higher in deucravacitinib group compared to the moderate to severe patient population overall. And also when you look at the MACE events, deucravacitinib the patients that were treated with deucravacitinib do not have increased rates of MACE events either. Now, because as a field we recognize TYK2 being a very targeted treatment for our psoriasis, because of that, our field is advancing with even more TYK2 inhibitors in clinical development. And I think that is a big statement in terms of we are making as a field in terms of our confidence in TYK2 inhibition. And this is very important. We do not have any oral JAK1, 2, or 3 inhibitors for psoriasis. We have them in atopic dermatitis, but not in psoriasis. In psoriasis, we are doubling down on focusing on TYK2 inhibitors. And you'll hear more about these TYK2 inhibitors in the coming years as more TYK2 inhibitors become approved. Now, the key thing here is, can we make TYK2 inhibitors that's even more specific and therefore able to go up on dose while maintaining a good safety record. So right now, there are two molecules that are in late phase development that are being studied. One of them is zasocitinib, and the other one is ESK-001. And so let's take a look at zasocitinib. I was fortunate to be involved in the clinical trials, both for the phase 2 and also now for phase 3 clinical studies for these molecules. So let's take a look at zasocitinib. So what we're seeing for zasocitinib, here you're seeing the PASI 75 and PASI 90 data, which are both very, very encouraging. At the present time, we don't have head-to-head with deucravacitinib data. Also, I want to point out for zasocitinib, for the PASI 100 data, based on the phase 2 studies, we have about a third of the patients on zasocitinib achieving PASI 100. So we're looking at TYK2 inhibitors that are aiming for higher and higher efficacy, close to and equivalent to that of biologics. But we'll see what the phase 3 data turn out to show. And then this is ESK-001, another TYK2 inhibitor, again, being extremely specific in terms of how it binds to TYK2. And what we see here also very robust efficacy for this newer TYK2 that's in development, and also very well tolerated as well. So very encouraging results for our patients with plaque psoriasis. Okay, speaking of patients, let's get back to Jeff. So for Jeff, moderate psoriasis, prefer oral. So I think Jeff would be a good candidate for TYK2 inhibitor here. And in fact, Jeff was treated with TYK2 inhibition. Here we see before and 5 months after. And we know that lower extremities can be difficult to treat, actually. And what we see is that near complete clearance of the psoriasis, not only on the thigh area, but also we see in other parts of Jeff's involvement of his body as well. Okay. Now we're going to pivot. We're going to say goodbye to Jeff, and we're going to look at another patient. So let's meet Tony. Tony is a 46-year-old man with psoriasis and scalp symptoms on apremilast. So here we see Tony. What we're seeing is lots of flaking around the scalp, most prominent, very prominent around the retroauricular area, because that's where we can see the scalp a little bit better. But please, when you do examine patients with psoriasis, definitely look at scalp overall. In the hair-bearing areas, it can be very tricky to examine, but it's definitely well worth the effort in order to appreciate the extent of involvement. I also want to say scalp is around between 5 to 7% of the total body surface area. So if you have a patient whose entire scalp is involved and may have, let's say, 3%, 4% elsewhere on the body, that can account for about 10% BSA. And then that patient can be considered oftentimes for a systemic therapy. Okay, let's go back to Tony. So Tony reports a 12-year history of psoriasis, not very well controlled on apremilast due to some of the ongoing GI side effects, and is bothered by the scalp involvement. As we know, for patients, especially with scalp involvement, there's a lot of itching, there's a lot of flaking and desquamation, and also it affects their clothing choices. They oftentimes will only buy light color clothing because they may be embarrassed that the flakes can fall on their dark clothing. And as you can see here, significant also impact on the quality of life, and the plaques are thick here. So PGA of 4, right? So the plaques, thick plaques. So the question is, are there data for deucravacitinib, for our TYK2 inhibitors, for specifically thinking about scalp? So let's think about our POETYK-PsA1, PsA2 studies again. So these are patients with generalized plaque psoriasis, but who also in this particular analysis, we're looking at a subpopulation who also have moderate to severe plaque psoriasis of the scalp. So what we see in this subgroup analysis is that if you have generalized plaque psoriasis, and you also have moderate to severe plaque psoriasis of the scalp, what you see is that about 70% of the patient population here will achieve clear or almost clear after 4 months. Now, this is significant improvement. And that improvement is also superior to apremilast. As you can see here, about 40% of the patients on apremilast achieve clear or almost clear of their moderate to severe scalp disease from baseline. And then this result is also replicated in the sister study. Now, what about long-term scalp response? So what you see is that 70% of the patients initially achieving clear or almost clear, if you follow them throughout time, they maintain that clearance over time. So when you're looking at 1-year data, the rates are very similar. We don't see a drop off. We see nearly 70% of the patients, 69.7% of the patients maintaining that through 1 year. Now, there was also a study that was done called psoriatic scalp study that specifically looked at patients who presented with moderate to severe scalp disease. So in this study, it's focusing on patients with moderate to severe scalp disease, and they may have limited body surface area. So this is important because for patients who have predominantly scalp disease but don't have much psoriasis elsewhere, that's oftentimes considered even more difficult to treat scalp diseases. So it's a slightly different beast compared to the patient population that we talked about before. You can probably think about some of your psoriasis patients. They just have very severe recalcitrant scalp disease, and they may not have much involvement elsewhere. So what we see in this particular study with a very difficult to treat scalp population, we see about nearly 50% of the patients will achieve clear or almost clear by week 16. Okay, so let's go back to Tony. So Tony, remember, having significant scalp disease and had been on apremilast, but felt that it did not control it well. And the question for us is, would you consider TYK2 inhibition for Tony? And how would you navigate the treatment selection for Tony? So we'll have everyone kind of think about this particular question. And let's take a look at what happened to Tony. So let's revisit Tony here. So here's Tony. We see the baseline here. And then after a few months of treatment with a TYK2 inhibitor with deucravacitinib, and what we see here is a complete clearance in Tony's case. So very good response to deucravacitinib for Tony, who has this severe scalp involvement. So it really speaks to the ability of TYK2 to impact these high impact areas and being able to get our patients to clear, almost clear. Now, let's say goodbye to Tony and let's welcome our third patient, Sharon. So Sharon is a 56-year-old woman with long-standing psoriasis and new onset of PsA. So let's take a look at Sharon. You look at Sharon's images here. As you can see here, pretty significant involvement of the torso. Sharon also has a nail pitting and onycholysis. You see nail ridging there, but ridging is actually not quite a sign of psoriatic nail disease. We see nail ridging with just as a part of the aging process, but certainly pitting, onycholysis are very much one of the common findings of psoriatic nail disease. But also very importantly, you see some joint swelling and tenderness. And then when you talk to the patient, and also you notice on physical examination, the patient has tendinitis around the Achilles area. So also an enthesitis in that area. Okay, so is there data to support TYK2 inhibition for patients with psoriatic arthritis? Now let's take a look at this image. So I know this looks quite busy here, but this really speaks to the shared pathogenesis for psoriasis and psoriatic arthritis. And what we see is that the same master regulator, IL-23, being involved, and also same type of cells, principally Th17 cells that are involved, that are then secreting IL-17 and IL-23 that are involved here as well. So there are a lot of shared pathogenesis between the two conditions, which is probably not surprising why also a third of the patients with psoriasis will ultimately develop psoriatic arthritis if untreated. Now let's take a look at deucravacitinib efficacy at week 16 and week 52 for POETYK-PsA trial. So this trial looked at whether deucravacitinib can be effective in psoriatic arthritis. So it's a very important study. And what we see here is ACR 20, 50, and 70. And for each of those outcomes, so that's at least 20% better compared to baseline in psoriatic arthritis signs and symptoms, or at least 50% better, or at least 70% better. And for each of these outcomes, you see week 16 and week 52. So the takeaway from this is that deucravacitinib is efficacious in patients with psoriatic arthritis in terms of ameliorating or decreasing the signs and symptoms of psoriatic arthritis. And when we look at week 16 data and then later on at week 52 data, what we see is that the improvement continues after week 16. So when we're looking at week 52 data, you notice that the bars are even higher compared to week 16. And so what we showed here is that deucravacitinib demonstrated this superior and also sustained efficacy across a number of different domains, not only musculoskeletal, the skin domains as we talked about, but also in terms of the quality of life endpoints for patients with active psoriatic arthritis. Okay. Now, what about zasocitinib? We have in our emerging therapies, remember we have zasocitinib and ESK-001 on the heels in late phase development. We also have zasocitinib efficacy in psoriatic arthritis. And here what we see are different doses of zasocitinib showing efficacy over placebo in terms of PsA. So another nice confirmation that TYK2 inhibition not only affects psoriasis, but also affects psoriatic arthritis and can bring down the disease signs and symptoms in PsA. Okay, let's return to Sharon and let's take a look at Sharon here a little bit further. So in Sharon, we note that Sharon had been on methotrexate 15 milligrams weekly and some occasional use of clobetasol. So Sharon is now being managed by a traditional oral therapy methotrexate for both psoriasis and psoriatic arthritis. However, psoriasis, as you can see, is not under control, and also psoriatic arthritis is not under control either. So the question is, can you consider choosing an agent that can address both? And especially if Sharon prefers oral therapies, how that can change your decision-making process. So let's take a look at Sharon. So Sharon was treated with deucravacitinib. We have before and after. The after photo is, as you can see, a year after deucravacitinib, complete clearance from baseline. Very importantly, however, let's take a look at also the joint disease. So when Sharon had her joints imaged at baseline, you can see the bone erosion in the right third distal interphalangeal joint at baseline. And the patient was treated with 2 years of deucravacitinib. And when the imaging occurred again in this patient, what we saw is not only a halting of the progression of joint disease, but also by imaging, this patient also had bone erosions no longer being there. Now, I would say bone erosions disappearing are probably overall, regardless of treatment, a less frequent event. Most of the time, for most of our therapies, whether it's deucravacitinib or other or biologic medications, we see an inhibition of progression of radiographic damage. So, but in this patient, it's unique. It's, I would say, very encouraging that not only was there an inhibition of the progression, but also you see essentially in this particular patient, we don't see bone erosion there anymore. So almost a reparation of the damage that's there. Okay, now we had I think a really good discussion on the 3 patients, earlier patient cases. I want to highlight some of the key points now to really have us think about the use of TYK2 inhibitors. Currently, we have one FDA-approved TYK2 inhibitor in psoriasis, and that's deucravacitinib. Some of the advantages is that it has no box warning, it has no known drug-drug interactions, and it's well tolerated. And the rates of, for example, nausea, diarrhea, it's the same or even lower than the placebo. It's efficacious, it's superior to apremilast. We now have also long-term data showing the efficacy. It's convenient. It's a pill that can be taken with or without food. And in most of our patients, no laboratory tests other than pre-treatment TB is needed before we start treatment. And the reason for that is that because TYK2 inhibition is so specific, all the clinical trial data have supported that when we look at the laboratory test that was done as part of the clinical trials, um, there were no perturbations in the laboratory for the vast majority of the patients, and that's why our thinking and evolution also have evolved over time to a more simplified approach to laboratory evaluation in these patients. Importantly, we saw the PsA data for patients started on deucravacitinib in the clinical trial setting, also having efficacy. Okay, so just to kind of summarize the clinical snapshot of deucravacitinib, it's once a day, 6 milligrams for patients. Again, no test required prior to initiation other than TB evaluation. If you have someone with known or suspected liver disease, you can evaluate liver enzymes at baseline and thereafter. And of course, when we're thinking about selecting an oral therapy, there are other things that come into play. And you want to ensure that you have individualized discussion with the patient, but also taking into account other comorbidities. The way I oftentimes approach this is I look at patients' disease severity and I ask for their preference. And then I say, based on your presentation and your preference, and also, of course, we look at their insurance status to see what they can gain access to. I'd say my recommendation is this, and what do you think? I don't present them with all of the different systemic options and say, pick one, because it can be very difficult for our patients. So I offer a direct opinion and then get their thoughts, and I get their feedback, and I also watch their body language. Sometimes you can tell they're a little hesitant. And if that's the case, I ask them, do you have any reservations, or what are your concerns? And it's really important to address that concern during the visit, because otherwise you may be prescribing a medication, but the patient actually has some reservation they didn't voice, and they go home and they don't take the medication. So that would not be good. So really thinking about choosing this individualized therapy for the patient based on their preferences, based on the likely performance of the medication and their comorbidities. Okay. So this is my thoughts on the use of TYK2 inhibitors, especially deucravacitinib at this current time. I think it is ideal for systemic naive patients. So for our patients who would qualify for systemic therapy, who haven't started on the systemic therapy, who is tired of topical therapy cycling, that deucravacitinib can be very helpful. I think deucravacitinib's sweet spot is for those with a bit more moderate forms of plaque psoriasis rather than the very severe end. We saw the efficacy for high impact areas such as the scalp. And of course, deucravacitinib would be a great option for those who would desire an oral option. I went over this earlier. Again, I know monitoring is laboratory evaluation is always a hot topic and deserves some reiteration. Again, universally in everyone, the only test required is TB evaluation before you start. That's the only universally required one. And if you have patients who may have known liver disease or suspected liver disease, you can check their LFTs. Now, I think the care of psoriasis patients really takes a whole village, and it's very important as we are thinking about caring for these patients and their comorbidities that we work with other specialties, especially rheumatology, and oftentimes with their primary care physicians to ensure that their other comorbidities are cared for, not just psoriatic arthritis, but also their cardiovascular comorbidities, also their mental health comorbidities. So those are also very, very important. And for patients who may not be able to access you, um, also think about telehealth capabilities as a field that we can kind of think about how to bridge some of the gap for our patients who may either be underserved or underserved in a way in which they're living in geographically remote areas where they may not have dermatology expertise nearby, how we can use technology such as telehealth to bring them closer to us. So, in conclusion, we talked about advances in psoriasis pathogenesis have really led to effective therapies. And we spent a lot of time today talk about TYK2 inhibitors. But it's time well spent, if I could say so. And also, very importantly, we have two additional newer TYK2 inhibitors in late phase development that we're likely going to see in the future, being able to bring those to our patients. And oral therapies is really the new frontier in psoriasis treatment. And among them, TYK2 is extremely important. And for our already approved TYK2 inhibitor, deucravacitinib, we talked about its use, most beneficial in those with a bit more moderate disease rather than very severe disease. And also the ease of use, once daily medication, they can take it with or without food, no known drug-drug interactions. So I think it's a very, very a good oral option for many of our patients. And then finally, we touched upon how a personalized or team-based approach is very important for our patients working with our rheumatology colleagues, even if we know that, for example, deucravacitinib has good coverage in the joints, but oftentimes it's very important to have the patients further evaluated just to make sure that we're not missing any other inflammatory arthritides or that the diagnosis of PsA is correct. And with that, this brings our discussion to a close for today. I hope that you found this activity informative and useful to your practice, and I encourage you to also access the supplemental program materials. Thank you very much for participating, and have a great rest of the day.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/SMF860.